they have to have the appropriate transporter function to get them through their blood. And once it goes there, then we have to make sure that, when they go to metabolize, in the enzyme system, there's no interaction there that will slow them down or increase their level. And then, for sure, we know that they excrete from the kidney and liver, and we have to make sure that the patient is a suitable case for excreting the medication properly. So this is going to be the overview of who cannot get these medications. So from the absorption zone, I think I've just named 3 anatomical situations that you don't have a good absorption. So look at the right side. So we have apixaban, dabigatran, edoxaban, rivaroxaban, and warfarin. You see the absorption of all these, mainly the main absorption zone is the distal stomach, just going all to the duodenum. Your patient has a Whipple procedure done. Not a good idea to put this patient on. The people, they have Whipple procedure, they have the gastric bypass surgery, Rowan-Weiss surgery, and they have the blue pancreatic diversion and duodenal switch. So they are the one that you have to, sort of exclude from this, pod and then go the other route. The other thing is that if the one that they have organ dysfunction, and the one that they have a drug-drug interaction. They have, if you have it inducer drugs on inducer drugs and inhibitor drugs, they can simply decrease and increase the concentration of the medication, and that affect your treatment. I'm not intending to to just list this medication for you. I just want to give you an overview about how we can look at it. So look at this. Give you example, verapamil, calcium channel blocker here. So it's a weak to moderate inhibitor, but when used within an hour with dabigatran, can increase the dabigatran level by 180%. This is one example. The other example is our patient. The patient has a seizure disorder, the patient with a calf DVT and popliteal DVT that you just saw. So this patient was on carbamazepine, and carbamazepine reduced the level of the apixaban, so to the point that it may not be as effective for your treatment of the recurrent DVT in this patient. So we have 2 reasons this patient not to consider the direct oral anticoagulant. One was a Whipple procedure, and second being on a seizure medication. These 2 basically move us away from these good options that we use on a daily basis. So I give 2 other examples, like rifampin and ritonavir, so for the patient with the HIV. But we have the list available, definitely in the database, but as long as you have the mentality that, okay, well, make sure that my patient, is an appropriate case for direct oral anticoagulant. So, one more question about this patient. So we said that the patient has a non-obstructive coronary disease, and the patient is on aspirin. So do we really need to continue the aspirin in this patient? So, in the past, there was an individual decision based on calling the cardiologist, going back and forth with the internist, whether we want to keep the aspirin, we want to continue this, let's take it for now. I think now, with this patient, we don't need to continue the aspirin. I just want to get your attention to a consensus that we have with the American College of Cardiology. This is the scenario that we're facing, so the rest probably is going to come in a cath lab, not directly to a primary care physician or podiatrist or family physician, but this is what we have. We have a patient with a non-obstructive coronary artery disease and now has a venous thromboembolism. So we have a consensus since 2020 that these patients, they don't need to stay on aspirin. You can take them off. So this patient has a non-obstructive, no recent procedure, no recent stent, and you're committing with a full dose anticoagulation. And it's an older adult, so increase the risk of bleeding. So, and I'm not intending to go through all details, but we have this consensus, detailed, agreed, multi-society guideline that's available and published by American College of Cardiology now. And this particular example, you come across a lot when you start treating a deep vein thrombosis for this patient. So, I just want to make sure that we pay attention to these 2 components, the anatomical Whipple procedure plus, the medication interaction. So another example, again, for a direct oral anticoagulant where we shouldn't use